Hi everybody, welcome to our very first pre-GA webinar 2020 of MSF Holland. We will have our General Assembly on the 13th of June at 10 o'clock starting as was planned. However, because of all the corona, we cannot have your presence here physically in the office. And we're extremely sorry for that. We miss you and we would have loved to discuss with you and have a vibrant associative life here in Holland this year at the GA again. What we've tried to do is compensate a little bit for all that's missing now, and we've organized 3 online webinars. You're watching the first one today. We want to take you along so that you know what you're voting for, what you're accepting. Today we'll discuss the strategic plan, and we have 2 very distinguished guests, Nelke Manders, our General Director, and McRae, our Medical Director, who will explain the most important part of the strategic plan for the coming years. Next week, same time, please join us again. We will have 2 people explaining the accountability statements. One of them is Peter Wiskett, our Financial Director, who will actually help you how to read the financial statements so that you know what you're voting for. And the last one we will dedicate to our COVID response as MSF and MSF OCA. We hope you enjoyed the sessions. Please do vote online and please join us at the General Assembly at 10 o'clock on the 13th of June. Thank you.
Hi everyone and welcome at this first pre-GA session. Thank you Marit for introducing us. This first pre-GA session is about the OCA Strategic Plan 2020-2023. Thank you all so much for joining. My name is Marguerite, I'm the assistant to the board and I will be hosting this session for you today. And before we start, let me briefly explain why we are hosting these pre-GA sessions. Because hopefully, as you've heard by now, the General Assembly this year will be held 100% online. And we hope by organizing these pre-GA sessions, we can help you get used to this kind of online event and get used to the YouTube platform. But much more importantly, we want to give you the opportunity to ask your questions and discuss some of the topics that we will be addressing at the General Assembly itself. So for these pre-GA sessions, your input is very important and I would therefore like to encourage you to submit any questions you may have via the YouTube chat. You can find the chat somewhere on the right side of your screen and make sure you're logged in with the YouTube account so you can ask all the questions that you like. If you do end up having any technical issues or you would rather submit your questions via the email, that's fine as well. Just drop us an email at the association address and Marieke will be ready to answer all your questions. So that's a bit of the brief technical information, but let's quickly go to the topic for today's session because that's much more interesting. As we mentioned before, today's session is about the OCA Strategic Plan. And we will be discussing that topic with 2 of our guests, our General Director and OCA Chair, Nelke Manders, and our Medical Director, McRae. Thank you both so much for joining and for taking the time to be with us. It's been quite a while since we've been here all together in the office. So how are you doing, first of all?
Yeah, thanks for asking. It's very nice to be here actually and to look you in the face.
I know, yeah.
So I quickly walked up and down the stairs to see a few other colleagues that also are here because they have to work together. And I had a few sessions already online with other colleagues, but yeah, nothing can beat the face-to-face. Yeah. Although it is great that at least we now have organized this way of acting. But thanks for asking. Hope you are doing well too.
I am. How are you, Melissa?
Yeah, also doing well. I think trying to connect as much as possible, but it's allowed us to use lots of different ways of technology, both to connect to the field and within the office, but the face-to-face you can't replace.
That's always the best, yeah.
Nice to see a few people today.
Great. So for this session, we have basically asked you to tell the members a bit more about the OCA SP 2020-2023. And perhaps it's good to give a bit of background information there because the SP is quite new. Correct me if I'm wrong, but I think it was finalized in the beginning of this year or the end of last year. And as the name suggests, the document contains the plans, the aims and objectives for the coming 3 years. And our members of the MSF Holland Association are asked to adopt the SP at this year's General Assembly. However, as you may perhaps know, many of our members no longer work for MSF or perhaps haven't read the document before. So we thought it would be a great idea if you could introduce the document to our members and pick out some of the highlights that you think are interesting for our members. So basically, what do you think the members should take away from reading the document? That was our question to you. And I know that you've both been very involved in writing the document, so I'm sure there's a lot you can tell us. But perhaps if it's okay with you, Nelke, I would like to invite you first to tell us a bit more about the SP and pick out some of the highlights for us.
Yeah, thanks a lot, Mariette. And you have it over there, right? The document.
I do. There's a hard copy there.
There is a hard copy. There is an online copy. And what I will do is max 10 minutes, give an overview of the entire strategic plan, and then Melissa will much more go in depth on more the medical components. And again, nice to be with you. Even though I can't see you, it's really extremely appreciated that you take the time and effort to invest in understanding where we are now as an organization and what, through a quite intense process, we defined as being the dot on the horizon. So again, strategic plan is really all about that. How to take stock of where we are as an organization, how the context has evolved to define that dot on the horizon that is then a kind of compass for us to guide our actions in the coming years. So it shows a lot of ambitions, and we really try to still remain realistic. In that taking stock of where are we now as an organization, we actually figured out that we can be extremely proud of how we developed a strong foundation. And there was not so much debate whether we are actually supporting the right people. So we do have the idea that we are assisting the people that truly are most vulnerable and excluded populations, that we are in the right places. Very much the thinking has been about, and how do we act? And how do we interact amongst us as staff, with other actors in the field, but also with you and our donors, our supporters. I want to share with you that the process has been, I already mentioned, intense, because we choose to be very inclusive in the process. And so we really have been trying to involve all staff that we have in OCA, so we talk about 11,000 staff, to truly ask about what they see as the strengths, but also the developments in the context in our organization that require a clear direction from us. And so it's even though it's true that Melissa and I have been involved in the writing, it is very much a document that is the result of all that interaction. We also had the luxury to do a few more in-depth research projects that fed into this strategic plan. So there was one research done by our reflection and analysis capacity in OCA to really look into our projects and how we interact, work together with other actors in the field, including the Ministry of Health. And the other research project was much more a result of what members like you through the years in MSF have been pointing out to us, and that is that we have evolved as a very diverse organization with 45,000 staff worldwide, but that the way we evolved does raise a few question marks about equity and inclusion. So we also did an in-depth research where OCA was in the lead that fed into this strategic plan. But so far about the process, but I think it's important for you to know that this is more than just a document that we wrote by a few people. This truly is the result of a process that was rather intense in in harvesting the ideas and the wisdom from all our staff, as well as being challenged by externals. There is a slide, and I think the technique will actually allow us to see that slide, that captures a little bit the overview of our strategic plan. So it's a slide that tells us, like, okay, what are we are a value-driven organization, what are the values that we work with? And I will not repeat them here, you can read them on the slide. The values and the way that we made that analysis of where we now are as an organization in our development, as well as what are the developments in the context, resulted in defining that dot on the horizon where we want to pay additional attention to. And that's very much, as you can see on the slides, about the interaction, as well as how can we harness all the capacities and capabilities to have the best possible impact for the people that we assist. And it defined our 4 strategic pillars, the strategic directions for the coming few years, as well as an additional chapter in how we actually work. But the 4 pillars are person-centered care, it is about our staff, it is about us being part of a global organization, and it is about igniting change and enabling action. And these are just a few words, but they have a lot of meaning if I think back of that process of 1 year. And it won't do justice if I just fly over in a few loose sentences. But I will do so before I pass the word to Melissa to go more in depth in a few of them. But those 4 pillars are again very much based on the how we work. Again, there was no question of who we assist, but very much on how we work, how can we further evolve, how we interact amongst us in staff, with other actors in the field, how we can leverage the potential of all of us, the supporters, association members, staff members, actors that we work with. And let me stop rambling and just go pillar by pillar very briefly. First one, person-centered care, can be short because Melissa will go much more in depth. It's more the result of global evolution of that concept, person-centered care, which also made us reflect on how can we ensure that we truly build on the capacity that each of our patients brings, with also their own support system, their family, the community even, and how can we build on that capacity jointly to have the best possible outcome. Much more to say, leave that to Melissa. Second pillar, staff. And we made it a separate pillar because we truly have the idea that in the evolution of MSF, there is a great strength that we want to maintain. And that strength is our expression of international humanitarian solidarity, which we express by having diverse teams. So over the decades, there's always been about 10% what we call international staff and 90% locally recruited staff working together in teams. And the international staff now truly comes from the whole world. What we notice is that there is an evolution in the capacities in the field. Many of the locally recruited staff either have had very good schooling and expertise built up in other NGOs, other areas, which make them become key staff in ensuring the continuity of our projects and the implementation of our strategies. Where in the past it was truly reliant on international staff to be in those coordination positions. But we also listened carefully to those voices over the past decade in MSF of locally recruited staff telling us that we have an issue with equity and inclusion, that the way that we build up our systems need to be reviewed to ensure that structural barriers that we maybe are unconscious of are going to be addressed. So that is part of this pillar, to ensure that the best person will be on the job and that everyone has the same possibilities to further grow and bring their full capacity to our social mission. In that staff pillar, it's also important to know that we are fully aware of the importance of our leadership and people management capacities in our organization. I'm quite sure that Melissa will say something about the complexity of our projects. That it's very different than 10 years ago, what we now expect from our staff to do in those projects. And that requires quite a lot of skills from our leadership and people management. So that's an area where we are going to further invest, build on the foundation that was already laid in the past strategic period. So we talk about person-centered care, staff. I move to the pillar igniting change and enabling action. That is a strategic area where we take stock that we have become quite a big organization. With a reputation worldwide, with networks worldwide, with donors, 6 million donors worldwide. And we fully realized that is a strength that we want to use, we want to leverage to the fullest to create positive impact for the people that we assist. And we do that through our strategies in our projects, but we also choose 3 areas where we pay additional attention to make a difference worldwide, connecting the dots, cross projects, cross missions. And those 3 areas, one Melissa will further give in detail. It is about antimicrobial resistance. Other area, it's about climate change and environmental degradation, the impact it has on the people that we assist. And there is one area which is much more focused on a trend that we all are aware of and that need our fullest attention and all the leverage that we can use. And it's about dehumanization of people. Again, much more to say about these 3 areas. You read a little bit in the strategic plan, or you can read it afterwards. And I'm sure that there will be more attention paid by the association to go more in depth in another forum. So I move to the last pillar to then wrap up. So please bear with me. And the last pillar is about global organization. And so what we realize is that the way we've been founded by French, and then we evolved into European headquarters. So we now have 5 European headquarters. But also with a vast growth over the past decade, we now see that in parallel, but then 5-fold, I don't even know what the English expression is for it, but by 5 operational centers, we have been growing as an organization with offices worldwide. And these offices also have matured with their own boards and their own associations. And we think that now there is a time in MSF to actually take stock of all that capacity and to maybe organize ourselves slightly different, to make use in the best possible way of those capacities worldwide. And we talk about some important global hubs like in Nairobi. How can we as 5 operational centers ensure that capacity, an important place in the world, is best servicing our entire organization. So moving in a way from a European organization with very diverse global staff to a global organization. And that pillar is also very much building on the research that I pointed out in the beginning that we did, the research amongst our own staff in how to ensure that we are diverse, and we are already diverse, that we remain diverse, but that there is also equity and inclusion. And that all our staff can contribute to the fullest to our social mission. In that sense, we also want to ensure that we support the capacities of local recruited staff in becoming the leadership in MSF, so that we have a truly representative leadership of our workforce. So that's in a very high over. our strategic plan overview. There is another chapter much more focused on how we work, how we are going to do all this, but that's for another time. So I think I can give the word to Melissa.
Yes, well, thank you so much, Nelke. I think that's really interesting and gives a really good overview of the SP, so thank you so much. If you have any questions for Nelke, just put them in the chat already and we'll come back to them during the Q&A. So for now, of course, I would like to give the floor to Melissa. Nelke touched upon it already, but we've asked you to delve a bit more into the medical sections of the report. So please, if you could take us along in that section of the SP.
Certainly, thanks Margaret. And thank you all for joining us this afternoon. I think it's great to be together online. I've done a little bit of a different approach this afternoon. I know many of you have heard us talk about this over the period of consultation. But I wanted to touch on three of the medical priorities that come out in the strategic plan. And whenever I do this, it's also important just to recognise, as we all know, these are three medical areas that we wanted to strengthen and focus on in the next 4 years, but it doesn't also take our focus away from all of the other medical humanitarian programming that we do that isn't captured in the SP. We will keep on treating patients who have primary healthcare needs, running surgical facilities, doing reproductive health, TB, HIV, malaria care, all of the things that actually we do as comprehensive care in MSF. But in the strategic plan, there are a couple of medical priorities that we wanted to zoom in on so that we can make sure we're able to evolve and do those areas well. The ones you'll see in the SP are the antimicrobial resistance, of course, then the health impacts of environmental degradation on the people that we are there to help, and of course person-centred care. What I'll do today, as you all can access the SP online, so please do that. You'll see aims and objectives for each of these. But what I've done today is actually invite two of the health advisors. They're newer health advisors to us, so I thought it was nice for you to also meet them virtually and see faces. And I've asked them to speak on the topic as well in a mission. So you can actually hear what is happening in this area in a mission to give you a little bit more depth than just what you might read in the strategic plan. So if you can help me, thank you. Let's start with person-centred care. One of the aspects I think we can really be proud of as MSF is that this is now present in each of the operational centre strategic plans, and we have synchronised the timing of those plans this year. So it really is an aspect that the whole of MSF is looking at. I'll give you a moment to read that slide in front of you, but it's person-centred care is about patients actively participating in the care they're receiving, having ownership of how they wish to be cared for and what the choices they can make in their life, obviously still guided by medical experts who have the answers and the options, but taking into account more of what is needed in different contexts and for different people, what different communities might need. It is very much about considering the human being as a whole. And I think you will, obviously each of us can also connect to this in how we receive healthcare in our home settings and what we would want as human beings. But person-centred care has been around since the 1970s. We already do it in a lot of our missions, but what we're really looking for in this strategic plan period is to make sure it is actually a key component of how we are doing our programming. Are we culturally appropriate? Is the programming we're doing there really meeting the needs and respectfully responding to those for the communities that we're trying to reach? At this point, let's introduce Mark, who will speak to us about Nigeria.
Hi, my name is Mark and I am the health advisor for Nigeria. For patient-centred care has of course become increasingly important as we try to deliver on a strategic plan. And Nigeria, we have a good example of how this is working. COVID has caused huge disruption to our programming in Nigeria. And in the IDP camps that we work in Anka and in Benue, we have adapted and we have performed community interviews and assessments where we have went directly to the community and spoken to them about what their attitudes and perceptions around COVID are, but also to the bigger health needs that they face. And this has given us an incredible window into the communities that we work in, but also into the attitudes and perceptions of what people want and need. And by doing this, we've put patients absolutely at the forefront of our decision making. We have put patients at the centre of the care that we provide. And in that way, we are delivering the strategies put out in the strategic plan. So I'm very excited to be continuing this work in Nigeria and to give our patients a platform to decide on actually what they want. So thanks.
Thanks, Mark. Hopefully next time when you're in and around the offices, you'll get to see Mark in person. Let's move on to the Igniting Change pillar that Nelke introduced. There are two components of this. One is the impact of climate change and environmental degradation on health. We have very purposely kept our focus in what could be a very broad topic encompassing climate change as well, on the health, and keeping it to the core focus of our social mission as MSF. On the next slide, we will see just why is this actually important to us? Why can we not, as a medical humanitarian organisation, ignore some of the changes that really are also the deteriorating mental health needs of populations, and just the increasing need to adapt our services to really help that in a culturally appropriate way. Thank you. The aims and objectives, so we're just coordinating slides here, is actually, the focus here could be a huge topic, as I mentioned. This really is to aim that we need to start and recognise where we're coming from. We need to start collecting the data. So in our impact assessments of missions, can we actually start incorporating some of this information so that we're collecting the data? We can actually then adapt the expertise in that area, or hopefully also join up with partners who are already experts in this area, share what we gather as data, help communities speak out for themselves on what they see as the issues, and share this data into global, to have a global impact, is really one of the areas we can see that MSF already, in the way that we're programming, we can help with that. We don't wish to build a whole wing of environmental health, but we can already contribute and team up with other organisations around the globe, both local and globally, who are already doing initiatives like this. Some of the objectives you'll see is recognising, first of all, the impact on the places that we already have operations, and where feasible, tailor our programming to try and address those needs, be that the changes in malaria or other vector-controlled diseases because of shifting water levels, the changes in nutrition because of shifting rainfall, climate conditions that change harvest and agricultural areas. They have an impact on health in the people that we are there to help. We're also going to develop the alliances I spoke about so that we can share the data and it can have a larger effect, not only in that context, but as Nelke mentioned, joining the dots and making that connection at a larger level. Of course, we wouldn't be MSF if we also didn't try and make sure we've got an advocacy component here. What are the legal ramifications where possible, and where are the policy changes that we can help communities change for where they live? It's a newer and exciting area for us, I think, in the next 4 years, but it will go well beyond that, which is a nice segue into antimicrobial resistance. You'll see on the slide in front of you, it says antimicrobial resistance and antibacterial resistance. Why do we speak about antimicrobial resistance as OCA particularly? It's because it's bigger than just antibiotic-treated diseases. It's about HIV medications. Where is the resistance for second and third line HIV patients? But also malaria. Malaria resistance is already sweeping through Asia. We're seeing it in Africa. We need to be ahead of this as an organisation who helps so many people with these diseases. So you'll hear us speak about AMR. I think the objectives are clear, and I'll give you a moment to read this slide. One of the key areas of why this is included is in igniting change. On the next slide, we see that it's really about global blind spots. So the context we work in are the low and middle income settings. They need to be included and at the beginning of this journey, as well as the high income countries. Many of you know you're working in hospitals in the Netherlands and in other places around the globe. This has been a big issue. It's been on the table for a while. We will not address it in 4 years. This will be a 10, 15, 20-year ongoing part of our services. But we want to make sure that the developments and the global energy that's going into policies, going into funding, going into where laboratory and microbiology capacity can be, actually from this point in time actually targets the needs in low and middle income countries and is not only targeted at high income countries who have the funding and the laboratory capacity to do this. So it really is about collecting data again so that the communities can know what their resistance patterns are. We can provide effective treatment for the resistance patterns that we're seeing, but also we can say at a policy level, what can be used in places like Central African Republic? What can be used in places like Nigeria? Let me just quickly on a technical slide run through the 3 pillars of AMR. This is an intersectional approach. We have had an intersectional task force existing for almost 3 years, but it will help you understand the next video as well. The first pillar is infection prevention and control. Obviously, this is well established and being well utilised in the COVID response at this point in time. The next one is antibiotic stewardship. How well do we prescribe? Do we prescribe antibiotics even if we think somebody has a viral infection? How well do we explain to patients how well they should take the antibiotic? How do we responsibly prescribe our antibiotics across MSF missions? And the third pillar is laboratory and diagnostics. It also includes disease surveillance patterns. We will, as MSF, have to strengthen our laboratory capacity in combination with local partners, but it's a key part to being able to actually determine where the resistance patterns are and how we can provide treatment that works. Let me introduce Abdul to give us a snapshot of what's happening in South Sudan.
Hello everybody, my name is Abdul Wasim Mulazada, health advisor based in Amsterdam, supporting South Sudan and Venezuela missions. I wanted to share with you some progress made around antimicrobial resistance AMR on behalf of South Sudan mission. AMR is considered, the approach to AMR is considered 3 pillars within MSF. Infection prevention control, IPC, antibiotic stewardship, and access to diagnostics and surveillance. I am sharing only experience around antibiotic stewardship, although IPC is also implemented. Binti Hospital carried out a baseline point prevalence survey in July 2019 to understand the issues around prescribing practices as a baseline, and another one in February 2020 this year. There has been a significant improvement observed around range of indicators from 15% to 20% on an average last year, to an improvement to up to or above 60% in most of the indicators, and that being on documentation, rational use of drug, adherence to protocol, reviewing of prescription of antibiotic, and also considering switching intravenous to oral regimen or treatment as well. The most important point here I want to share is that these exercises and practices are no longer considered as threatened or an extraordinary audit procedure, but but part of the routine activity led by senior medical staff, local medical staff at the department level as part of the AMR committee. To a level that some of the department supervisors wants to carry out these prevalence surveys within their department on a monthly basis to guide their monthly training plans in support to the team. Thanks.
Go. Oh, okay, so welcome back, and I hope you got a little bit of insight from Abdul what's happening in Benchu. I will just add that the committees he's talking about is that in missions where we are having AMR as a topic, and we will gradually roll that out across the portfolio, but we had to start in a few select missions. They have a national staff committee that provides continuity in this area, which international staff then come in and support during their missions. But the training and learning opportunities for national staff among the 3 pillars is one of the key things we'll be trying to deliver in the next strategic plan period. With that, I hope I've given you a quick taste of what we're doing, and happy to answer some questions.
Thank you so much, Melissa, for your presentation. I think especially for me personally, being non-medical staff, this really helps me to better understand the medical section. And let's indeed go on to the Q&A. We actually have some questions coming in already. I have my laptop here with me, so I can read them to you while we go. And please, for our members, you can just continue sending in your questions, and I will see them popping up here, and we will make sure to answer them. So let's see, our first question is from Mary Gallagher, and she asks that in the strategic plan, we mentioned that we will strive for gender equality in the leadership of our projects. Is there already a specific plan in place to make that happen?
No, thank you for that question. And I was very happy that this was actually added to the strategic plan, because we are fully aware that we work in many societies that where it's not obvious for women to get equal opportunities to further also develop and enter actually in our organization, but then even grow into leadership positions. So we know it will take an additional effort, and a conscious one, for it to happen. For many of the things that are written in the strategic plan, we are actually now making the implementation plans. So we have tried to formulate as a management team, but also with our teams here in headquarters, what we think are the feasible actions that we can start with in 2020. And as you know, with COVID, everything has slightly been put upside down. And you see that some parts of the strategic plan are really accelerating, actually, because it's really what is asked for now in this context. So which is painfully great, and other parts are delayed. So we are still working on some of these areas to make the plans for it, and to be specific about it. In 2 weeks' time, the leadership will come together again in the planning and control cycle moment, the mid-year moment, where we actually will redefine, like, okay, where are we now, and what will we do for the remainder of 2020, and how do we look at those plans for the longer term? So that will come.
Good to hear, thank you. We have another question coming in. This one is from James Smith. And he says, we mention inclusion and equity as priorities, much needed, he says. We talk about structural barriers that we may be unaware of. Are there plans to investigate these barriers so that they are more visible? I'm not sure which one of you would like to respond to that.
No, I can kick off, because that's exactly why we did that research last year. And so we listened to the motions that were handed in over the years, year in, year out, where the voice was very clear that there are issues, and we wanted it to be more explicit. We wanted to understand, like, what are we not seeing, of what are the barriers. So in that research, and there is a report of it that was also issued last year in MSF. We did that research together with 8 other sections, and OCA being in the lead in MSF. So in that research, we actually also interviewed a lot of staff worldwide, also brought staff together in Rome, Dakar, to go more in depth on those first findings that we got through the desk research and through the interviews and through some surveys. And in that research, you see much more explicit, like, what is it that is actually blocking equity and inclusion? And there is now a transformational investment capacity program, as we call it in MSF. Those specific efforts that we all fund from MSF jointly, those specific efforts put in a program to just address all these barriers that have been identified, but also to stimulate that awareness, because it will only change if we are aware of what is blocking, to consciously address it. So that program has started and will take at least 3 years. But it's also, like Melissa is saying, for many of those areas, we know it will take much longer. And these are not intentionally barriers, but it's more on how our organization was established and has evolved. So I'm not going to clearly answer to James' question, like, what are those barriers? But yes, we already are aware of quite some, and further to be explored and addressed in the coming few years.
Thank you, Claire. A third question we have coming in is about patient-centered care. So that's one for Melissa. It's from Ramatullah Aljani, and he asks, how can patient-centered care be dealt with now that we are scaling down on some of our activities?
Ramatullah, good question. I think we're refocusing some of our activities, certainly in COVID times, but I think that the person-centered care can exist regardless of which the activity is. It's actually about how does that connection happen between a caregiver and the patient? How is the patient receiving that? So it might look different in different consultations or in different areas of medical service delivery, but it can exist regardless of if we were running 2 programs or if we are running 76. So I don't think that is a barrier to us that I see at the moment. The barrier at the moment is it does take time to slow down, to actually connect and understand, and take that moment to actually understand the needs of the patient in front of you and the broader community. And that can sometimes be hard in the chaos of COVID at the moment, but we will get there.
Thank you so much. Then our fourth question, we have many questions coming in, so thank you for that, and just keep on submitting your questions. We have another question from Jacques D'Emiliano. It's a long question, so I hope I get it right, and if not, just mention it in the chat and we can ask again. Jacques says, concerning antibiotic stewardship and prescription practices, being a general practitioner, we see a huge prescription difference between, for example, the Nordic countries and the southern parts. How will MSF bridge those differences between the medical staff?
Yeah, Jacques, it's a really good point and something we have been talking about. Not only the differences north to south, but the differences in medical hierarchy in some cultures. In a culture I come from, actually a pharmacist can correct my prescription as a doctor, or at least say to me, are you aware of this? That doesn't exist in some of, and it's certainly not an accepted norm in some of the countries. One of the things that go hand in hand, and it's a good link both with person-centered care as well, how do we do cultural change? How do we do awareness raising among our staff of what is needed in different cultures? But how do we actually do over time behaviour change? And it does take continuity and investment. But I think being able to do an approach that actually works alongside with many ministries of health are also now having national action plans on antibiotic or antimicrobial resistance. How do we actually see from the ministries of health in those countries what works in those countries? How can we tap into some of that if it's suitable for the ethos of how we'd like to deliver our programming? But having a context-specific approach is one of the challenges, but I think also is the way to go about it to get that result achieved.
Thank you. That's a very interesting question. I never thought about this. We have another question coming in. This is one from Ramatullah again. And this time he asks about the training being a part of the pillar in Band 2. He asks, how much do we give space for the field learning and development professionals to let them apply proper learning processes?
Yeah, there is always more work than we have. So part of what we're very cognizant of is actually, firstly, to have national staff in key positions here. Many of them already have these competencies from their own learning or learning within MSF. But if we want to actually get the results we need, how do we invest in that? Part of that is actually doing on-the-job training. So shifting our learning strategy so that it's on-the-job training, mentorships, maybe doing less of 1 and 2 week blocks. How do we connect peer-to-peer networks between missions? So people in the same leadership positions, if you're an antibiotic stewardship focal point for Benchu, how do we connect you with the hospital in Lashkar, Afghanistan, or Zamfara, Nigeria, so that you can meet other MSF staff who are doing the same job and connect and help each other problem solve, but also provide solidarity to each other. We are also looking at formal training systems with, as we all know, online is hugely possible. How can we actually set up mechanisms where we can have staff doing training, get formal accreditation for that, but have the training that they're learning really actually designed and adapted by MSF so that it's suitable to our needs?
Thank you. I see no more questions coming in from the chat, but I did have a question myself. I hope that's okay, because I read the OCA.
It's your prerogatives.
You're a member.
I'm a member now, yes, that's true. No, what I thought was very interesting is that I read that OCA aims to make more allies among civil society networks and communities and social movements. And I was wondering, do we already see operations where that is happening, and what does it look like?
Yeah, good question. And in its strategic plan is really building on what we already see happening and where we see potential to further build on, right? So I think the most obvious one is our operations on the Mediterranean. If you, I think even the choice for starting that project was very much connected to what was the strategic pillar in the previous strategic plan. Where we wanted to see how we can actually have more impact for all those people that have to flee from their homes. And then are meeting high walls, barbed wires, or even imprisonment. So the SAR project was really a project where all this also comes together, combined with the Libyan detention centers. We try to connect the dots and just tell the story of what we see, where people are fleeing from some of our project areas, where they get stuck, if they then manage to get out of detention centers in Libya and take a boat and go on the sea. There are many actors that have the same aim, to actually address those migration policies, the rights of people to, the right to flee, which is a human right, to then get protection. So we have been lining up with many other actors that have that same purpose, and sometimes it's happening behind closed doors, but we share data, information that then will also be used for the lobby by other actors. But we also, of course, really try to connect with a lot of our MSF sections. MSF sections that weekly then came together online to actually exchange the different efforts in their home societies and to stimulate jointly the best possible strategies for MSF, but then also tailor-made for the different sections. So that joint advocacy capacity in MSF was very powerful, and it was a bit of a pilot to do it like that, to have that co-ownership of the strategy in that project. But an interesting one to further build on if you look at leveraging the capacity within MSF. But it's that whole range of trying to connect with all those people that support us worldwide, to raise that awareness, to also see how they can support our call for action if we have a call for action, So the supporters, the MSF staff worldwide, the association members, and the specific power of the different offices of MSF worldwide.
Okay, thank you, thank you. Let me see if we have any more questions. Otherwise, I have one more question, of course. And this one's for Melissa, really, because I had a question about the antimicrobial resistance. I must say I had never heard of the word before working at MSF. I'm very sorry. But what I read in the SP is that MSF aims to adapt global policies and guidelines to meet patients' AMR-related needs. And then I thought, which sort of global policies are affecting those antimicrobial resistance? I didn't really understand.
So there's a number of different global platforms you can imagine coordinated by the United Nations bodies, but also by other significant funding bodies, because this is not just a problem of low and middle income countries. It's a problem across the globe. You know, there have been hospitals shut in European countries because they can't manage the resistance rates. So the global policies that are coming out are around the measures that should be taken around hospitals, how hospitals should be built, what is considered best practice, should actually every patient be tested prior to being admitted to a hospital. That might be very feasible in a high income, highly resourced setting. What does that actually mean in lower and middle income settings? How are we going to know what the resistance patterns are? How are we going to know what the access to, you need access to the laboratories to actually determine the resistance. So it's about making sure those policies are written for multiple different economic levels and different development styles across the globe, as opposed to just being possibly focused. And here you know, of course, it's a little bit of a generalization, but the funding is coming from the countries who are often high-income countries. They are concerned about this problem, and it might be very easy to just focus on higher income settings. We did see that in the TB-HIV era. The medication was initially available to the countries that could afford to purchase it. We don't want the same thing to happen again with AMR, and it's not to say it's happening. I mean, AMR has also been a problem for more than a decade, but how can we be at least a voice in those right platforms globally? But also maybe it's not for MSF to sit there. How do we find space for the people who are coming from the context we work in? But we might be the people who open the door for them and say, have you considered who's represented around this table? I think that would be a really positive impact.
Okay, great, thank you, thank you. I'll have one more look at the, oh, there's a question. Let me see. Oh, this is a question about the impact of COVID on the SP. It's a question from Hugo, I think Hugo Smees, one of our members. And he asks, how do we prevent the disruption of regular care during this COVID pandemic, really? We are, of course, having a separate pre-GA session on this as well, but I totally understand the question, so it's a very relevant one, I think.
Hugely relevant. Can I take it?
Yeah, of course.
So really good question, and it's something we have to keep asking ourselves so we don't take the focus off it. COVID in itself, yes, it's a pandemic. The global mortality beyond belief, absolutely. But what we need to keep a focus on in MSF is women don't stop delivering babies. People don't stop getting malaria. In some of the countries we're working in, they are too scared now to come to a hospital because they think they will get COVID at that hospital. How do we actually go about making sure our community engagement, our messaging, and that we can continue delivering services in a safe way, whilst also contributing where we can to the responsibility to treat COVID? It is a really tough balance. I know different missions are having to do it differently, but what we are really worried about is that the indirect mortality of COVID, so the shortage of other services, the lack of access because of the efforts being put into COVID, actually might have a far higher mortality than actually the pandemic in itself, and they won't be captured in pandemic figures. So what we have done as OCA, just to be very concrete, is actually really prioritise what we have called life-saving services, and we have kept all of those open. Have we had to reduce a few of the Other services that we're doing, some of those are outreach services. Yes, we have. It has been minimal, but we've also had to balance that with actually having capacity to treat COVID. One of the benefits of COVID, if you can say there are any, are the fact that so many of the cases are mild and actually can be identified, although we don't have a lot of testing in where we're working as MSF, but identified and cared for at home. And it's actually a really great opportunity for us as MSF to strengthen how do we do home care, how do we do outpatient care. It's something that we're absolutely putting energy into, but it is a balance.
Yeah.
There is no silver bullet to that question.
Thank you. We'll discuss that more in the other pre-GA event. I see, looking at the time, that it's already 4 again, so we've been talking for an hour already. So that means we've reached the end of this pre-GA session. I would like to thank you very much for joining and for telling us more about the OCA SP. I think, speaking for myself, it's incredibly helpful, and it really helps me to better understand the SP, the document. And I hope also for our members that it helps them to vote on this document and perhaps read it one more time, and then they have a better view of the strategic plan. So thank you very much, and thank you also all for joining us, for watching. If you do have any questions still on the SP, you can always email them to us or write them down, and make sure to ask them at our GA, because then we will also have a Q&A with the whole board present, so you can ask any questions you like, and we will be happy to answer them. For now, I hope to see you all next week, same time, same place, June 5th. And then we will be talking about the accountability statements and the financial statements with our delegate director, Martje van Nes, and our head of finance, Peter Wiskert. And they will tell you all about the accountability and financial statements. So make sure not to miss it. Please tune in, and we'll see you then. Thank you. Bye-bye.
And maybe already on the 2nd of June, right?
Yes.
So on the 2nd of June, I think you all received an invite to join, again virtual, the memorial moment that we have every year as OCA, in which we take a moment to consciously honor the lives of those colleagues that we lost. And of course, it was only recent, the 12th of May, that we had this atrocious attack in Kabul, costing the lives of many mothers, Hazara mothers, that were there to deliver in our maternity clinic, including the life of one of our midwives, Mariam. So it's painful. It had just happened. Then in that weekend afterwards, there was the communal fighting in Piri, which made the whole community having to flee, and that also cost the life of one of our staff members. So it all just happened, so additionally painful to now have to share that with you. But on the 2nd of June, we take that conscious moment to honor the lives of not only them, but of all colleagues that we lost over the years. So please also do join that moment if you can. And thank you, Margarita, for organizing this. Thank you for all of you to have listened to us. Really appreciate your questions and your engagement. It's together that we make a difference. Thank you.